I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor.
We're going to talk about cramps today and why you shouldn't ignore them, if you even can. I don't think we can ignore cramps, but why we shouldn't ignore them from a diagnostic perspective. And I want to share a little bit about what we're coming to understand or know about endometriosis, how close we can get to understanding if people have endometriosis before putting them under the knife, and also the why it's important for us to understand your menstrual cramps from a central sensitization perspective, from a nerve perspective. We know that some of the development of chronic pelvic pain in women comes from untreated pain, right? So having long-term pain actually increases the likelihood of you having chronic pelvic pain. And that's why I want to bring this conversation to light, because we have so much misinformation about cramps and endometriosis. We have so much diagnostic delay on this particular topic that I wanted to dive in. My history with endometriosis is a long one. And actually, I don't think I have it. I don't think I personally suffer, although there have been moments in my life, especially when I was a youth. I remember specifically being a lifeguard in my adolescence and like keeling over with this like crazy cramping spasm thing that would happen occasionally around my period. And I always wondered if maybe I had a hint of endometriosis, but my interest in it actually stemmed from much more of an academic perspective. It's very common for practitioners to have this personal relationship with conditions that they get really invested in and passionate about. And I don't actually have endometriosis, but my personal academic relationship with it is a long one. And I've really spent a lot of time reading and researching on this particular topic, and I've watched the research change. The spirit of research has changed over the last 15 to 20 years that I think is worth noting and worth sharing kind of on this larger audience. I actually did my very first paper on endometriosis when I was a third year university student. I took an advanced immunology course that, we basically had to do this kind of mini thesis type paper that spanned the entire course. And then we had to defend that paper at the end with the immunology professor, who was quite a crusty individual, actually. He was one of those professors that made you feel like you were like wasting the oxygen in the room, because like there were maybe smarter people than you that could have been using that air. Anyways, it really pushed me in the course. I've let that go. Maybe I haven't. I've let it go. I'm saying it because it really pushed me in that course, for better or for worse. I mean, I certainly don't think that we should be pushed because of fear in education, but for better or for worse, I was really pushed in that course. And it was right on this time where we started to look at the immune system of people with endometriosis. And we're finding that there were differences in the immune cells in people with endometriosis versus people who didn't have endometriosis. And I know that sounds like such a small little piece, but really it was this first look at the major differences in why we think endometriosis even gets going in the first place. Like, what is different about those people that allows menstrual tissue and endometrial tissue to grow outside of the uterus and perpetuate there. That was that first glimmer. It was back in 2000, I think it was 2002 when I had written that paper, maybe 3. I then spent time looking at it from a naturopathic perspective. So after I went to the naturopathic college, my 4th year project thesis type presentation was also on endometriosis, where I collected all the data on anti-inflammatories and other options that maybe were available to patients with endo. I presented it, and then I actually really shortly after graduating published that paper in a integrative medical journal at the time, which was like, what is our role as naturopathic doctors with endometriosis? I spoke on it a lot. That topic, I was invited to speak at McMaster and at medical schools, etc., about this particular topic. But it wasn't until I was cold called by a colleague who had a relationship with the endometriosis clinic at McMaster that they needed to move on from. And they were like, I've been watching you and your relationship with this condition. Is this something that you would consider taking over for me? Which of course I said yes in a heartbeat, like the opportunity to work hand in hand with the gynecologists and really like gynecologists that work with endo are some of the most compassionate people I've ever worked with. They work with women in pain all day long. They're just a wonderful team of people. I absolutely jumped at that opportunity. So I've spent a lot of time looking at this condition. And when I say the spirit of the research has shifted, I've been watching it for 20 years, take various shapes and forms. And we would maybe imagine that research doesn't have a spirit or doesn't have a theme to it. But I'll share with you, like through the course of this podcast, and as you're listening, as someone who maybe suspects they have endo, or maybe you have cramps, and now I'm going to try and convince you to look at it through a different lens to make sure that you don't have endo. We're seeing a shift in the way we talk about this condition that I think we're all going to benefit from, actually. So one of the big challenges we've had with endometriosis is that the gold standard, meaning the very, very best way we have of diagnosing it at this time, is through laparoscopic surgery, meaning that you actually are having an operation where they use a laparoscopic camera, or perhaps they even like visualize it themselves, which that's probably rarer. But we use a laparoscopic camera that then visualizes the actual tissue. So that's how we can tell if someone has endo, or that's how we've that's how we thought we had to tell if someone had endo up until perhaps like a little bit more recently. And so when something's the gold standard, that means that, from a research perspective, we're really only going to set eyes on solutions that have made sure that people actually have the condition before we test something, right? So we want to know that people have endo before we do research studies on people with endo. And so in the past, we've only included people who have what's called laparoscopically confirmed, meaning we looked, we saw it there. Laparoscopically confirmed endometriosis were the ones that we've studied. They're the ones we've paid attention to. They're the ones that have definitely had the most airtime as far as research goes. But as you can probably imagine, when we make surgery that diagnostic hoop that you have to jump through, very different than like going to the lab and having like a simple blood test or doing a quiz, and then we figure out that you have a condition just based on your quiz answers. When something is diagnosed by surgery, we bottlenecked our diagnostic process at a hospital table, right? And hospital time and operating time and surgeons. And now if we maybe have 1,000 women who suspect they have endo, maybe we're doing surgery on 3 of them to see if they do. And so really, the research for the better part of our understanding of endometriosis has been an underestimation of true population values. There's probably more women who have it than we think. It's really been an underrepresentation of people in research, because people who never got surgery and never got confirmed never went into any research. And so it's really, a few years ago was tainting our view of this condition. But you think about all the things that would have to happen for someone to get an actual accurate diagnosis. They'd have to go to their doctor, which there are communities right now where that is a privilege. They would have to present their pain from their menstrual cramps in a way that their physician started to be curious that they maybe had endometriosis. And there's some really recent papers coming out about, certain communities and certain cultures that are underrepresented in the endometriosis research, because it's taboo for them to talk about gynecological symptoms, period. They may have language barriers that prevents them from being able to explain to their physician what's going on with them. Or perhaps even culturally, we've normalized some level of menstrual distress in people month to month. And so now they think it's normal. So maybe they're not going to go to the doctor because all the women in their family used to have to spend a day in bed with their period cramps, and so do they. So all of those things, like you have to go through all of those checkpoints, then you have to be referred to a gynecologist, and the wait times are very long at this point. That gynecologist then also has to agree with your doctor. They then have to set you up for a laparoscopic investigative surgery. And so you can see, like, we've got a million hoops we need to jump through. And so what do most women do, right? They pop 2 Advil and go to work. And so the couple things I wanted us to get out of this time together today is, one, we're actually starting to develop a slight understanding of who might have endo without doing surgery. And I'm going to give you a couple of suggestions or things you can think about there. I also want you to feel empowered to take care of your menstrual distress, because we know that left unattended, we wire pain circuits to basically have chronic pain in people who have chronic pelvic pain that are not well addressed. And then I want you to feel confident bringing that up with your doctor and perhaps accepting some solutions. So I do see in the online space with talking about menstrual cramps and endometriosis, there's definitely a shame-filled conversation and a guilt-filled conversation about people using medication to manage their symptoms. And I really want to take that away. I want to take the wind out of those sails and say, if you have chronic pelvic pain and we're pretty suspicious that you have endometriosis, your mental health and chronic pain hinges on you getting support. And so I want you to feel confident that getting treated for it is important. So there's some interesting work around diagnostic delay for endometriosis. So I alluded to a few of them there, right? Like culture, language barriers, certainly access to healthcare. There are some low resource communities that maybe would struggle to even get access to the kinds of things I'm talking about. But we generally think that there is about an 8 to 12 year lag from the moment that someone starts to suffer enough with their cramps that they actually seek support to the time that they're actually diagnosed with endometriosis. So to jump through all those hoops and then go through the laparoscopic surgery, it's 8 to 12 years. And a recent study, actually, which was just published in the last month, October 2022, actually started to look at diagnostic delay by age. And what they found is that the younger the patients were, the longer it took for them to diagnose them. So in their youngest group, it was people aged 9 to 19. That was an average of 14.8 years for true diagnosis, whereas when people were over 30, they were diagnosed in roughly 2.9 years. This was an Italian sample of 700 people. So it's actually like relatively representative. And what that means is, and what I take away from that is that for young people that are presenting with menstrual cramps, one, we maybe have a hard time collecting enough information on them for us to feel like they have endo, because some of our diagnosis of a person who's in their 30s would maybe include their fertility history. And if people have menstrual cramps and infertility, we are like flagging them immediately as having endometriosis. Whereas a younger person, who just has menstrual cramps in air quotes, I don't mean that. But we haven't collected enough information on a 14-year-old to know whether or not they have struggled with infertility, whether their ovulation is consistent or not. And the severity of their disease may not have caused enough ovarian changes or destruction for them to be riddled with other symptoms. That's partly where that delay comes in. And we generally don't start to do things like a diagnostic ultrasound, etc., to people that are over 18, 19, right? Like even when we're looking for other gynecological conditions like PCOS, doing diagnostic ultrasound in people under 18 is not that accurate. And so we've got this huge age range in there where people are developing endometriosis, and we maybe are starting to see some nerve changes in those people with endometriosis, but because they're young, we're missing the mark as far as assessing them properly. So my interest in clinical practice partly is how can we influence the decision-making tree of people when they present with certain symptoms. And endometriosis is kind of no different. It's the difficult part about talking about menstrual cramps is that the research suggests that women are generally not heard when they approach their care provider about this topic. Women, if they're asked like before their appointment, they actually anticipate being ostracized, or they anticipate their concerns being trivialized when they talk to their doctors, and actually also when they talk to their partners about their menstrual cramps. Like, so women actually believe that their concerns are not going to be listened to or taken seriously before they even walk into the appointment. And there also is evidence that suggests that doctors and partners actually do that they believe that their partners are complaining, and they even would maybe rate their patient's pain, or their patient or their partner's pain, as being less than the way that their partner or patient rates it. So you can see where we've got some issues, right? As far as like that primary care interaction, that women expect that their symptoms are going to be trivialized, and they are, right? And so for younger people, when they're approaching their doctor about these menstrual cramps, it's obviously they're not going to get the kind of question asking that we want to try and dig deeper, but they're also not going to get the solutions that we want either. So there are some questions that you should be asking yourself, and that your care provider should be asking you if you present with menstrual cramps. And when we run a diagnostic test, right, we like to see like this light switch, like yes, no, right? Like, yes, you have iron deficiency. No, you don't. Although there's not that many tests that are that dichotomous, right? Maybe like, yes, you have a strep infection. No, you don't, right? Whereas lots of things also kind of fall on this spectrum. But when we do a history taking and question asking, it's very rare that the answer to one question is like 100% like yes, right? So, it's very rare in clinical practice that we can ask you one question: do you have cramps? And you say yes, and that teaches us why. That's not how question asking and history taking works. History taking is actually a more dynamic conversation that requires us to capture lots of data points and lots of pieces of information that we put together to get closer to understanding a diagnosis. Because if we said to someone, do you have pain during your menstrual cycle? And you said yes, right? Give me a couple of examples of other things that could be from. Maybe you have IBS and it gets worse during your period. Maybe you just have simple menstrual cramps. Maybe you have endometriosis, right? There's a couple reasons why you might have pelvic pain during your cycle. If you say no, right, then what is it, right? You can probably give me a couple of answers of situations where people don't have menstrual cramps. PCOS. If you have acne, you might not have menstrual cramps, right? Like, you can see that they're not yes or no light switches, meaning like yes is an absolute yes and no is an absolute no. This concept is called sensitivity and specificity, and you don't need to understand it. And honestly, every time I get on stage to talk about it, I invariably will talk myself into a circle and have to come back to it and explain it again. But basically what it is how close can we get to understanding if someone truly has a condition by answering yes, right? And how sure can we be that they don't have something if they answer no? And with history taking, you can see that there's never going to be one question. We actually have to ask lots of questions. And with endometriosis, it's no different. So there actually was this neat study that tried to examine that statistical experience, sensitivity and specificity with respect to question asking for endometriosis. And the goal of it was, can we teach clinicians how to ask good questions to their patients that present with menstrual cramps to see who should be screened more closely for endometriosis. So here are the questions that they asked, and these are ones I want you to think about that with respect to yourself. So think about all the yeses that you're saying while I'm asking these questions. So one is having pain that gets worse during menstruation, pain that happens at ovulation, pain that happens during intercourse, pain that happens with bowel movement, or like that colicky kind of anal spasm kind of pain. Okay, so if you answered yes to any of those questions, keep paying attention. What about irregular periods? What about infertility? Okay, so those are some other things that we can ask patients about. And when we get answers to those questions, that can help us understand what's going on with them a little bit more, help us get closer to understanding if they have an endometriosis diagnosis. Now, some of the other things we should be looking at for primary care actually involve the physical exam. So palpating the uterus, palpating the sacro-uterine ligaments, and then perhaps even giving an ultrasound to show us if there's any lesions on the actual ovary. But those questions about pain, about infertility, and about irregular periods are trying to help us flag who has endometriosis and who doesn't. And so this cute study actually, I call it cute because there was not a huge number of people in it, and I was really happy with the results, so I'm calling it cute, was basically that when you started to answer yes or no to more than one of these questions, it started to raise our suspicion around whether or not you had endometriosis. So for example, if people had pain with intercourse and pain during the menstrual cycle, we were getting a little bit closer to understanding whether or not they had endometriosis. We were a little bit more confident. It was going to flag more patients if we asked those two questions. Now, if patients don't have pain with menstruation and they don't have infertility, then we were pretty darn sure that they don't have endometriosis. So rather than the question being like, do you have cramps, right? The literature on endometriosis has actually backed up a bit and gone, wait a minute, this condition affects women's lives like in a lot of directions. We actually should be asking all of these questions. And so when you go to share your experience, it's important that you share your answers to all of those questions. Because the moment you start to say more than just cramps, the more it tilts us towards us understanding your pelvic pain experience even deeper. Okay. And so that's what I wanted you to kind of take away from that. And when I'm talking about like, what's the spirit of the literature doing? One of the things it's doing is starting to acknowledge that endometriosis is way more than cramps. It's not just menstrual cramps. So our questions to you should be a reflection of that. We should be asking you way more than just about your menstrual cramps. We should be asking you about your whole life. So that's what I want you to take away from that sort of history-taking perspective. The other piece is that we are definitely seeing a shift in the conversation about diagnostic ultrasound being a way to diagnose patients with endometriosis. I actually have done a podcast with Dr. Matthew Leonardi, who is really taking the endometriosis world by storm with his research and teachings on diagnostic ultrasound for endo. Remember what I said at the beginning, if surgery is the way we find it, we're bottlenecking at an operating room, and many of you are being left unassessed. They're starting to look at the impact of using ultrasound to diagnose endometriosis. Now, you may have had an ultrasound already, and they maybe said something like, I'm suspicious of an endometrioma. And that certainly, I mean, if we see endometrioma on ultrasound, we're pretty darn sure you have endometriosis. But if they didn't, that doesn't mean you don't have endometriosis. And one of the challenges we have with imaging is that you need a skilled sonographer, meaning you need someone who is capable of looking, and they need to actually look. And Matthew and I talked about that in our other podcast, that we have an absolute standard of care of doing ultrasound for certain gynecological conditions, but we don't have a good standard of care for assessing for endo, which means patients are often they're not looking for it. And if the sonographer is not skilled, then they're also not capable of looking for it. And the ultrasound itself may not find it, but that doesn't mean you don't have it. So if you've had an ultrasound before and you're like, yeah, they didn't see anything, I would take that with a big grain of salt, especially if you've answered yes to more than one of those questions that I kind of stated at the beginning. So why is this important that we find it? It's interesting. I find the research on trauma and chronic pain and the nervous system so fascinating. And it really it hangs a little bit outside my abilities and scope. And sometimes when I read those papers, I feel like I'm like back in university trying to understand what some geniuses are saying. But the general theme of chronic pain and endometriosis I followed along for the last few years, especially as our understanding of which supplements to use has changed, etc. But essentially, a couple of the take-home points I wanted to touch on here is one, that your pain is not a reflection of how big or small your endometriosis lesions actually are. So you can have stage 1 endo and be in debilitating pain. And you can have stage 4 endo and not know. Maybe that's a stretch, but you can have a higher staging endo and not be as debilitated with your pain. And so the research is shifting to talk about neuropathic pain and central sensitization for pain, where your nervous system actually changes as a consequence of being in chronic pain. And if you have any kind of chronic pain syndrome and you're listening to this, this has probably been brought to your attention in other ways, but I want to specifically talk to it about menstrual cramps and about endo, because you can see that's this picture I'm trying to paint for you now. Massive diagnostic delay, right? 8 to 10 years, 14, 15 years if you're younger, and major bottlenecks as far as diagnosis, right? We cannot get you into an operating room to see if you have it. We don't ask well in clinical practice. We just ask about your menstrual cramps. We don't ask about all those other questions that I just asked you. And we send you home with, Motrin or Advil or a hot water bottle. But the chronic pain that's happening as a consequence of undiagnosed endometriosis is setting patients up for maybe a lifetime of chronic pain. And I don't say that to be fear-mongering. And if you have pain right now, I'm not saying you're going to have it forever. Your nervous system's brilliant, and we can actually change your pain perception over time. And there's some really interesting research looking at various techniques to decrease neuropathic pain, especially in patients with endo. So I'm not saying that you're going to have pain for a lifetime, but I'm saying unless we intervene, we're setting patients' nervous system up to recognize most things as being painful. And so when we see that central sensitization of pain, what that means is that your brain is deciding essentially, and your nervous system is deciding how painful something is, which is really fascinating. And when patients are presented with chronic pain, it changes the set point of what your brain finds okay, what your brain finds tolerant, and what your brain is resilient to. And I'm sure you've had that experience. And actually, funnily, when I used to do a lot of acupuncture in my practice, I could tell if someone had their period just by putting a couple of needles in, because they'd flinch. And they actually were less tolerant to the discomfort of the needles during that particular phase of the menstrual cycle. But central sensitization is where your nervous system is actually adapting because of chronic pain, and it lowers the threshold for what it considers to be painful, meaning that more things are considered to be painful. And this is why even after we surgically take out endometriosis, patients can still have pain. This is why people can have pain, debilitating pain, but their endometriosis itself is actually like kind of a stage 1, or it's very small and it's maybe not pushing on anything. But that inflammatory soup that's created in the pelvic cavity is triggering lots of pain perception. And this is why, in general, lots of anti-pain strategies for endo have not been particularly successful, because it's not just about blocking the pain like at the endo. It's about the fact that the nervous system has married the endometriosis and married that inflammatory response and decreased its tolerance for all discomfort. And so patients are in pain longer, more. It's difficult to treat. It's more treatment resistant. So you can see why this is important for me. We have a general underappreciation for this condition, a diagnostic bottleneck, clinicians that are not that interested in it. And it's that diagnostic delay is wiring the nervous system of people who suffer with it to become less and less and less tolerant of pain over time, and more debilitated over time. Right? That is a shitty combination. So where is the research going? So what I want you to take away from this, let's back up for a sec. 1, you need to answer those questions that I said at the beginning. Pain all month long, pain with intercourse, pain with bowel movement, pain with ovulation, pain with menstruation, fertility, right? If you're struggling with infertility, that's certainly going to raise our alarm bells for thinking about endometriosis. I want you to answer those questions. And I want you to go into a physician's appointment with those questions at top of mind, so that you accidentally don't just answer the "do you have cramps" question, because that doesn't give us the level of sensitivity and specificity statistically to know if you have endo or not. We need the answers to those other questions. It gets us closer to understanding you. I also want you to bring this up with your doctor. So again, part of diagnostic delay is the cultural issues we have with normalizing menstrual discomfort and menstrual pain. It has to do with lack of access to care and the fact that you maybe can't even get in to see your family doctor, or if you do, you're like going for something else and you only get 2 minutes, and so you can't talk about this. I really want you to leave this conversation today feeling empowered to have a deeper conversation about your cramps. 100% it might just be cramps, and that is so fine. I am totally happy to be wrong about you having endo, right? There's no ego in that for me. I actually would rather you not have endo. But I also can't stand how long it takes for someone to be diagnosed when we can get close just by asking good questions, doing a good physical exam, and sending you for a good ultrasound. So the last piece I want to leave you with is talking a little bit about the spirit of the research on endo and where that's shifting. Research is generally pretty reductionistic, right? We look at things in detail-oriented ways. We try and control outcomes as much as possible, and that's all very good, right? It's rare that research gets written in a compassionate way, right? Research is often like, yes, it worked. No, it didn't. Try this. Don't do this. There isn't a spirit of research very often. And when I first started reading about endometriosis, it almost talked about it like it was this alien, because truly those spots in like those endometriosis lesions behave differently than other body tissues, right? They affect the immune system. They perpetuate a ton of inflammation. They make their own hormones, and then they respond to those hormones. They create a blood vessel network that is very, very cancer-like. There's a lot of behavior similarities between endometriosis and cancer. They fight for their own survival and evade the immune system's detection. And when the research first came out about it, or when the research really started to talk about endometriosis, it was very textbook. The T cells are different in these patients. The peritoneal fluid is filled with, inflammatory markers. These patients are depressed more than other patients. It really had that. And most research does, right? Most research is not like thinking about Julie with endo, right? It's thinking about population statistics, etc. But what I've watched over the last decade with this conversation is that the research has shifted from that can't work, or that shouldn't work, or that doesn't work, right? Those were the conclusions of lots of papers. When they asked about exercise and diet and, for nutraceuticals and even pharmaceuticals, like generally it was like, that doesn't work, that can't work, that makes no sense, don't try that, that's a waste of time. And now the research is different. The research is actually starting to say, you know what? Women who try to change their nutrition to manage their menstrual cramps feel more empowered about their care. Women who feel better if they take lactose out of their diet because they also have IBS and it improves their endo, they should try that. We think that lowering inflammation in these patients might be a good idea. We support multidisciplinary solutions because these patients have high relapse rates. That's actually the conversation we're having now. We're moving towards, if it works, it works. And I find that quite encouraging because the research is shifting towards much more of this behavioral science, nutritional science, combined with conventional care. We know that we can't just cut it out of patients and send them home. It doesn't work. They actually need a contingency plan for when they go home after surgery. We know that leaving patients to their own devices doesn't work either because they feel ostracized by their doctors and that they never actually access solutions that can help them. So the research is shifting towards, let's listen to women. Let's hear what they have to say. Let's ask them what makes it better. Let's do research on what they've noticed. Let's support them in their choices. Let's try and help them get better. And I think that's such an empowered, cool thing to have watched over the last 20 years, where we went from Don't make diet changes in your endo patients because we don't think that can work. Don't you dare block your endo patient from trying something she thinks helps her. So the other piece I want you to take away from the conversation today, one is I want you to be screened for endo if you have cramps. And I would say if you're using Advil more than 3 days per month, and I'm kind of made that number up, but for me, that's a little bit of a tolerance point. If you have one really bad day of cramping occasionally, we're fine. If there's this consistent pain with your menstrual cycle that you feel like you need to medicate, I would maybe talk to someone about that. But also, if you're noticing that this is sounding an awful lot like you, and we want to avoid this long-term chronic pain syndrome that comes from central sensitization from chronic pain, it means we need to do something. And I want you to feel empowered to know that there are solutions that actually are great and that work. The last little thing I want to say is about drug therapy and conventional care. I was really disappointed. A couple months ago, I saw a post about one of the medications that we offer for patients with endometriosis. And the person or influencer had compared it to a chemotherapy drug and said, did you know that this drug is considered a chemotherapy drug and we're using it for patients with endo? Shame on medicine. We should be teaching women to balance their hormones instead. That was essentially what it said. And that made me pretty sad on a couple levels. Like one, that you just don't work with sick enough patients if you're going to suggest that celery juice and water and sunlight is going to take away someone's endo pain. I'm sorry. After working with the hospital for the last 10 years, I've worked with the sickest of the sick endo patients and patients who have really debilitating menstrual cramps who turns out actually probably don't have endo. I'm just not okay with this narrative that if you just tried harder to be more natural, that you'll get better, because you probably won't. And all that does is perpetuate this cycle of like maybe where you just don't talk about it anymore or you tolerate it. And I don't want that for you. So medication for endometriosis, the ones that we use currently, and this is in Canada and the US, are pretty effective. They decrease pain, they decrease lesions from growing, they improve quality of life, and they have a generally low discontinuation rate when we look at the statistics. Now, if you hop onto any message board and read about endometriosis treatment, you are going to get the salmonella poisoning chicken at my hotel version of TripAdvisor. It's not going to show you the people that are doing okay. It's not going to show you the people that got to go to work all month long because their pain was tolerable. It's not going to show you the people that, didn't have pain with intercourse because they took the medication. Nobody hops on a message board and says, this month my pain was only a 4 out of 10. You just don't see it. And so, unfortunately, when women don't feel heard by medicine, they turn online. And although I think that can be a wonderful way to get some baseline knowledge about what you might want to explore with your healthcare practitioner, it also really colors an ugly picture of conventional care. And I don't think that's necessary for this condition. We are doing the best we can for patients with endo. And you know what? If your pain is like a 2 out of 10, meaning low, don't use meds, right? If you want to truck through that, no problem. But if someone else's pain is a 7 out of 10 and they want medication, or they have a 2 out of 10 and they are a single mom and it is not okay for them to be in pain ever, and they want to use medication, I think as a culture in the conversation about endometriosis, we need to become more tolerant of drug therapy. I'm giving a talk for my colleagues this fall, and actually by the time this episode's published, I will have already done it, on endometriosis. And one of my slides says, for my naturopathic colleagues, do not block your patients from getting more, and I called it invasive, treatment options, because endometriosis is ruining your life. And the medications work great if they're chosen well, and we help support you while you do them. And so if you're listening to this and you're like, I don't think I have the bandwidth for, choosing something natural. This is not accessible to me to see someone who can support me right now. I want you to know that the conventional treatment options to support you are actually great. And don't turn them down. Talk to someone about your concerns. yes, this deserves more than a 4-minute conversation for you to feel good about it. But almost 100% of my patients who bring me a piece of paper from another practitioner and say, I was given this drug, what should I do? Leave the visit feeling very confident that it is part of a long-term solution for them. And so talk to your doctor if you're confused or unclear about what the role of medication actually is for you. But I do think that you need to read those message boards with a bit of a grain of salt, because nobody talks positively about medication online. I don't know why, right? I don't know why we wouldn't be like, look at this amazing science. It's changing my entire life and I can go to work not in pain. Instead, someone writes, did you know your doctor is trying to kill you by suppressing your hormones? I think we as a group need to change that conversation. I think we need to be super proud of people who seek help, who get help, who are helped. We have an absolute opportunity to do that with endometriosis and menstrual cramps. So, in summary, I feel like today was a bit ranty. In summary, answer those questions. Don't put up with your pain. Talk to someone who knows what they're doing. And don't decline solutions. That's what I want to say about endometriosis and menstrual cramps. I'll see you next week.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.